Thank you, Prof. Good afternoon, everybody. My name is Ruan. My group and I are going to be discussing COPD, an approach to primary care. So just to quickly, sorry. So I'm just having some difficulty moving on to the next slide. All right, so we're just going to quickly run through a bit of the epidemiology. Then Justin will talk about the pathophysiology. Tsepo will be going through presentation and clinical skills. I will briefly talk about investigations, and Hanrei will finish us off with management.
Right. So you want just a sec. You're able to move. That's fine. Just keep it to 25 minutes max, please. Thanks.
No problem. No, I'm sure we can stick to that. So as far as epidemiology goes, it's estimated that there's about 380 million cases worldwide, either diagnosed or undiagnosed. In Africa, the estimated prevalence is about 13.4%. Unfortunately, we don't have great concrete data available for South Africa and Africa specifically, owing to the lack of notification. It's more of a clinical diagnosis, and we don't really have robust data yet to support our assumptions. However, the BOLD study included Cape Town. It was a worldwide study done a couple of years ago, and Cape Town actually had the highest prevalence compared to other cities, or more than 20%. But given that loads of South Africans live in cities and our problems with things like air pollution, we can safely assume that the prevalence is going to be the same, if not higher, compared globally. So Justin will talk about pathophysiology.
Afternoon. So in terms of pathophysiology, the main risk factor, the main cause behind COPD is tobacco smoking. I read up that it contributes to over 90% of COPD. Other causes in patients who aren't smokers or aren't ex-smokers are environmental factors. So especially in less developed countries where they're using fuels indoors for cooking and heating, as well as air pollution in both developed and non-developed urban areas. That can also cause can be the noxious stimuli that's responsible for triggering the inflammatory response behind COPD, which I'll get into just now. And then a small subset of genetic disorders, such as your alpha-1 antitrypsin deficiency and your connective tissue disorders, can also be responsible for COPD, mainly on the emphysema spectrum. Can we just go to the next slide?
Sorry, Justin, I'm just, for some reason, it's not playing along with me.
What you do is when you are on the slide like this, if you hover on the left bottom corner, you'll suddenly see some arrows popping up.
Oh, okay, I can see.
Okay, great. So the main starting point behind the pathophysiology of COPD is inflammation. You'll have an inflammatory response due to a stimuli, either smoking or your environmental factors, or which will stimulate neutrophil and macrophages at the start of the stimulation. These neutrophils and macrophages stimulate the production and recruitment of elastases and proteinases, which causes lung tissue destruction, and ultimately that leads to airway narrowing and airflow limitation. In terms of your genetic conditions, your alpha-1 antitrypsin deficiency and your connective tissue disorders, there's no initial inflammation with your neutrophils and macrophages, and the way they cause COPD is via the elastase and proteinase. They start off there with problems in that area of the pathway. Yeah, next slide. So now COPD, it's basically, it used to be, there used to be two different entities that it was considered, chronic bronchitis and emphysema, and now they're considered to be opposite poles on the spectrum that we call COPD. And chronic bronchitis happens when your inflammation occurs in your larger airways, that is your conducting zone in your lungs. And the emphysema end of the spectrum is due to pathology happening in your respiratory zone, your respiratory bronchioles and your alveolar ducts and sacs. Yeah, switch over. So in terms of chronic bronchitis, you'll have inflammation, which through various mechanisms will ultimately cause airway narrowing and airflow limitation. You'll have your endothelial damage, which causes mucociliary impairment, impaired secretion clearance, and as well as that, you have mucus gland hyperplasia and metaplasia. And ultimately, you have increased secretions, which narrow your airway and block airflow. You'll also have fibrosis from this chronic inflammatory process, and smooth muscle hyperplasia, which is also a byproduct of this chronic inflammation process. And these all contribute to narrowing of your airways and obstruction of airflow. Next slide, please. And then again, emphysema, you have your inflammation, your destruction of the parts of your respiratory zone of your lungs. You get this loss of structure from your destruction of your alveolar, and basically these parts of the lungs collapse and you get airway narrowing. And because you have this destruction, again, decreases the elastic recoil of the lungs, and you're unable to, it's a functional obstruction as opposed to mechanical. You're unable to expire properly, and again, you have this airflow limitation. So yeah, I think we're moving on to the next person now, but just to re-emphasize, COPD is it's a spectrum of bronchitis and emphysema. You very rarely see someone presenting only with one of these entities, and it's usually somewhere in between, with both problems in the larger and smaller airways, especially something due to smoking, especially when it's due to smoking. With regards to your genetic causes, your alpha-1 antitrypsin and your connective tissue disorders, that's primarily associated with your emphysematous end of the spectrum. Yeah, thank you.
Thanks, man. Okay, so I'll be presenting the presentation and clinical science. So I think having an approach is of paramount importance, and once one understands the pathophysiology, marrying it to the clinical presentation of COPD patients, it makes it very easy to have an approach to this very common condition. There are four things that could suggest that your patient has COPD. One, the patient either telling you their condition. Two, a typical history of a slowly progressive chronic cough, shortness of breath, and sputum production. The onset is usually around midlife, and the patient having recurrent lower respiratory tract infections. And also the patient's medications such as bronchodilators and inhaled corticosteroids. Yeah, please move along. Once you establish that your patient has COPD, the risk factors and triggers one needs to probe during history taking can be divided into two: either the host factors such as the patient's age and hereditary deficiencies such as your alpha-1 antitrypsin deficiency, and also the other division could be the exposure such as smoking tobacco and the pack years, and also the environment such as air pollution and the socioeconomic status. Sure, next. So now that you've understood the pathophysiology and also taken extensive history, on your clinical examination, you'll be examining or looking for signs of airway obstruction and hyperinflation, which may be normal in mild or moderate disease. I think, as I was talking about the approach, the inspect, palpate, percuss, and auscultate approach works best in COPD, as the diagnosis can easily be made almost entirely on inspection and some percussion. The patients, so these are the clinical signs for inspection. The patient's posture is often very characteristic as they sit on what's called the tripod posture, where they have their hands on their knees and strutting the thorax so that their scalene muscles can yank their rib cage up and down. The patient might have alar flaring. The patient might be pursed breathing, have hollowing of the supraclavicular fossa. They also could have hypertrophy of the sternocleidomastoid muscle, a prominent sternal angle, also known as your angle of Louis, an increase in the AP diameter of the thorax, subcostal angle, which is normally acute. However, in COPD patients is greater than a right angle. And these patients may also have a Harrison's sulcus, coming about from the flattening of the diaphragm, contracting, thus pulling the rib cage in. And also the genesis of the Hoover sign, where normally when one breathes in, the subcostal angle widens, but in chronic obstructive pulmonary disease, the subcostal angle might actually narrow as the flattening of the diaphragm yanks the housing too. On percussion, a downward displaced liver and absent cardiac dullness may be elicited, and also on auscultation, decreased breath sounds on auscultation, and also early inspiratory crackles may be heard. I also found that it's also important to look out for signs suggestive of disease complications. And these signs include signs of respiratory distress, such as the use of accessory muscles, signs of polycythemia, such as conjunctival plethora, signs of pulmonary hypertension, such as a loud or palpable P2, signs of right heart failure, and also carcinoma of the lungs, such as clubbing. It's also good to look out for and notify the patient of possible treatment complications such as oral candidiasis, which may be caused by inhaled corticosteroids, and also a dry mouth in your long-acting muscarinic antagonist. Yeah, thanks, man. Sure, I think we can move on to the investigation.
Thanks, man. I'm quickly going to talk about investigations. I think appropriately so, we've spent more time talking about the history and the physical examination, because ultimately in the primary care setting, our investigations are quite limited. And as far as useful investigations go, it's pretty much limited to spirometry as far as getting useful information. But I will just quickly speak about chest X-ray findings, as well as your peak expiratory flow rate, and just some notes on spirometry. So chest X-ray, depending on who is interpreting the films, can give you either useful or no useful information. One study quoted it as a sensitivity of 90% and specificity of 98%, although in the study, 5 experts evaluated the films using a standard criteria form, whereas another study quoted it as about 35% sensitivity, thus showing how much it matters how skilled you are interpreting chest X-rays. But there are some very general findings. Specifically, I think we all look for the classic barrel chest with flattened hemidiaphragms and a small heart, which you mostly see in patients with the more emphysema type picture. And in chronic bronchitis, the findings are a little bit less specific, and they include increased bronchodivascular markings and possibly cardiomegaly. So as you can see here, you have flattening of the diaphragms, as well as this increased AP diameter characteristic of a barrel chest. And you might see a small heart in the more emphysema type pictures. But in most cases, I think you are limited to seeing just increased air spaces. Peak expiratory flow is an investigation that is available. The patient must inhale fully and form a seal at the mouthpiece and inhale, and this is repeated 3 times, and the highest measurement is used. However, it's not a great test for COPD because your peak expiratory flow rate just measures your initial force of expiration, which is highly dependent on the effort that the patient puts in. So depending on how hard they blow, the results are going to differ quite a lot. And why I said that spirometry is your only real useful investigation is because you can gain, you obviously get your forced vital capacity, total lung capacity, all of that, but we're specifically looking at your FEV1, which tracks your expiration force over 1 second, which is much longer than what a peak flow meter can assess. And if you look at your pathophysiology of COPD, the actual obstruction will be noted towards the end of the expiration when you need that last expulsion of air from the alveoli. And when you have reduced elasticity, that is more when you're going to see that. So you can, I think all of us will probably just Google one of these if we ever need to interpret a PFR. So I'm not going to go into that too much. And then spirometry. So this is an example of a lung function test. Like I said, your functional limitation is occurring during expiration and towards the end of expiration. So if you have air trapping, if you can see on that diagram on the top right, it is during your expiration that you will still have a mostly normal initial expiration of air, but then as the expiratory phase continues, you start to see the obstructive picture that happens there. And this is because you cannot sustain that expiration when you have COPD or bad COPD, shall I say. So ultimately, yes, I think try to base your decisions mostly off of your history taking and your physical examination findings. And only if you're lucky to have some of these investigations at hand, can they maybe guide your decision-making or help you track the patient's progress. So now I will be handing over to Hanrei.
Thank you. I'll be just talking about the management of COPD in our setting. Before we can start with managing COPD, we have to first be able to see when a patient has an acute exacerbation. So classically, they come in with a history of increased sputum volume, increased sputum purulence, and increased dyspnea. Additionally, they might have increased coughing or increased variation of day-to-day symptoms. Severe exacerbations are defined as being sufficiently severe to prompt use of an oral corticosteroid and or an antibiotic. COPD exacerbations are not always associated with your significant decrease in your PEF or your FEV1. And then also it's more dependent on your symptoms and measures of respiratory failure. These exacerbations are mostly caused by either a viral or bacterial infection and are obviously more common in winter. Okay. So general measures that we can take before we get to drugs is that the patients should be admitted to hospital if there's a marked increase in dyspnea, if there's symptoms of disturbed eating or sleeping, if they have a change in mental status or poor social circumstances. Patients also has to be worked up for other causes for an acute exacerbation, such as cardiac failure, PE, or pneumonia must be considered. In some settings, if there's availability, we can do blood gases for the presence of hypoxemia and hypercapnia. Patients with long-standing COPD, they actually change from their respiratory drive change from a hypercapnia to a hypoxemia. In these patients, if you give them too much oxygen, you take away their oxygen drive and the ventilation drive, and this will result in hyperventilation. So therefore, we start with low oxygen levels of 1.1 to 2 liters per minute via nasal cannula. If these patients, if their PaCO2 doesn't rise, it means you don't take away the hypoxemic drive, you can actually increase the nasal oxygen. Okay, we can go to the next one. Okay, so medicine that we look at first, we start off with nebulizing patient with salbutamol 5 milligrams. We do this continuously every 20 minutes at a flow rate of 6 to 8 liters per minute. If there's no response or poor response to this, you can add ipratropium bromide, 0.5 milligrams, also via nebulization. If patients fail to respond to this, you should discuss with a specialist if you have them available. Once they're clinically stabilized, you can continue with salbutamol. Also, it's important to know that you add your oral corticosteroids with acute exacerbation, first prednisone, and then you follow them with prednisone 40 milligrams daily for 5 days. If the patient is allergic to prednisone, you can or cannot use oral therapy, you can give them hydrocortisone IV, 100 milligrams 6 hourly. Yeah. Like I said, mostly the acute exacerbation are caused by either bacterial or viral infection in the winter times. When you think this is more bacterial, you can add amoxicillin 500 milligrams TDS for 5 days. If they don't respond to that, or they have one or more of the following symptoms of increased dyspnea, increased sputum volume, then you add amoxicillin clavulanic acid or augmentin, 1 gram 12 hourly for 5 days. Yeah. Thank you. I think that's it from us. This is just our references.
Thank you to the presenters. Any questions or comments? Thanks again for all the participants into our session. I wish you to have a very good afternoon, late afternoon and evening. Keep safe and see you next week. Or some of you, if they want to attend tomorrow afternoon, there will be a CPD meeting. Dr. Shane Murphy will present an ECG. Okay, bye-bye from me.